The following is a presentation for Week 3 of the Northwestern University MSGH Course 450 by Catherine Landa, Courtney Stewart-Rayner, and Sarah Kroll. The Global AIDS Response, an example of modern medicine at its best. Since it was first discovered in the 1980s, HIV has come to claim millions of lives and left millions more still infected. Where it was once a death sentence, it is now a chronic condition when managed with the proper medications and guidance from health workers. Getting to this point of chronically managed disease, however, has not been an easy task, as those working in the field of global health have needed to take a step back and look at the issue in a much different way than they ever did before. Where the field of global health was once dominated by policymakers, donors, and health professionals being socialized to scarcity, with few imagining that the field could be so much bigger than it was, the HIV/AIDS epidemic has spurred a new way of thinking, so that global health workers and leaders can think big, reach for new ways of funding, and attempt to combat the impossible. Utilizing a biosocial approach in this presentation to examine the pathway to global treatment of the HIV/AIDS epidemic, we will be able to see how many factors contributed to the response that the authors Mezek and Prabhu deemed modern medicine at its best. The first drug discovered to be effective at safely slowing the viral replication of HIV was azithromycin, or AZT. From its approval by the FDA in 1987 until 1991, it was the only drug on the market and carried a hefty price tag of $8,000 annually. Unfortunately, it also came with the possibility of creating AZT-resistant strains. Knowing all this, it is no wonder that only the richest in developed countries had access to this first miracle drug, leaving the poor and entire developing countries cut off from any chance at its use. Over time, more drugs were developed, including the first protease inhibitor, saquinavir, in 1995, and the first non-nucleoside reverse transcriptase inhibitor, or NNRTI, nevirapine, in 1996. These drugs would become even more vital when it was discovered that a combination of three drugs, coming from at least two different classes, for example, an NNRTI and a protease inhibitor, could be combined quite effectively against the virus. This became known as highly active antiretroviral therapy, or HAART, and is still widely used today as fixed-dose combination pills, though with even more effective regimens. As HAART became available in developed countries, stakeholders began to argue over whether it would be possible or logical to make HAART available in low-income settings. Most came down on one of two sides, that against or those for their use in developing nations. Those who did not think it was a wise endeavor to undertake often saw the HIV epidemic as a dichotomy. Either investments should be made in prevention or in treatment. Two studies in The Lancet, published in 2002, argued that prevention would be a better way to go, as it was more cost-effective than HAART or home-based care programs for treatment. The other major argument against utilizing HAART in developing nations is that the regimens were too complex for the people of Africa. When it first came about, HAART regimens were composed of multiple pills, taken multiple times a day at very specific times. With the use of fixed-dose combination pills, this is now a much simpler process. Failure to do so not only increased the chances of mortality, but also led to increases of drug resistance. Unfortunately, many people came to see Africans and other low-income citizens as unable to meet the strict requirements of taking these medications. Those on the other side of the argument, in favor of making efforts to use HAART in developing nations, began to gather evidence against these arguments. A preliminary study in Haiti using HAART found adherence rates to the medication higher than those in areas of the United States. Likewise, a study by Médecins Sans Frontières, Doctors Without Borders, outside of Cape Town, South Africa, saw viral load suppression and high adherence rates in their cohorts of patients using ARVs. The results of these studies challenged the presumed dichotomy between prevention and treatment, showing people that low-income citizens were just as capable of maintaining the regimens as others in developed nations. Evidence also showed how rates of testing and counseling increased as heart became more available to these patients. Thus, the possibility of receiving treatment functioned as an incentive for people to learn their status. Now that evidence had shown heart could be used in low-resource settings, the challenge became making it possible in the face of high prices of antiretrovirals and insufficient funding for their implementation. Drug costs for a 3-drug cocktail were in the range of $10,000 to $15,000 per patient year. While those in developed countries and those with health insurance were able to make this possible for themselves, almost all citizens of developing countries and those of low-income households were excluded. At the 11th Annual International AIDS Conference in 1996 in Vancouver, participants called for drug companies to tier pricing so that medications could be more affordable for all those in need. Their arguments largely fell on deaf ears. With heart expanding its availability in developed nations, the activist movements there began to dwindle. Those that remained were largely in urban centers and made up of those still achieving unequitable access to the drugs, such as the African American population in Philadelphia or New York City. These key groups that remained began to form transnational relationships with AIDS activists in developing countries, such as with the Treatment Action Campaign in South Africa, pictured here. The first country to make a large effort to expand heart access to all citizens was Brazil. In the mid-1990s, they began to produce and import generic ARVs using TRIPS flexibilities, such as compulsory licensing. Using these loopholes in the international trade laws, they were capable of lowering their drug prices by over 70% domestically. South Africa was the next country to make efforts at expanding access to heart to all citizens, and paved the way for almost all low to middle-income countries after them. In 1997, South Africa passed the Medicines Act, which would allow them to utilize both compulsory licensing and parallel importation to obtain the necessary antiretrovirals for the hundreds of thousands of citizens infected. Before this could begin, the government of South Africa was sued by 39 U.S. pharmaceutical companies, arguing that their Medicines Act undermined their intellectual property rights, weakening incentives for innovation and decreasing funds for pharmaceutical research and development. While this was a valid opinion to have, it was largely proven false by defendants of the law, who pointed out that the U.S. pharmaceutical companies in question were only deriving 5 to 7% of their profits from low and middle income countries, and that their current prices they were marketing antiretrovirals at were far and above what it costs to research and develop them. The U.S. government backed the pharmaceutical companies, going so far as to place South Africa on a priority watch list for trade in March 1999. Protests abounded in both South Africa and the United States, with many of Democratic candidate Al Gore's speeches and campaign stops being interrupted by protesters. By December of 1999, President Clinton had changed his mind, along with the rest of the U.S. government, in favor of South Africa's Medicines Act. The pharmaceutical companies would follow suit, with all dropping their lawsuits by April 2001, some even paying for South Africa's legal fees in the process. The most important development from this case came about from a World Trade Organization meeting in 2001, where the Doha Declaration was written and confirmed. The important document states that TRIPS does not and should not prevent members from taking measures to protect public health. Thus, low and middle-income countries were now free to use TRIPS flexibilities to import or produce the much-needed generic medications for their citizens. New methods were used in order to drive prices down even further. The Clinton Foundation's HIV/AIDS initiative, established in 2002, used pooled procurement to make antiretrovirals more affordable. They took orders from multiple health systems and governments, increasing the order size and thus demand, making the generic ARV producers increase their supply. By increasing both supply and demand, prices were driven down for those needing the medications, and profits increased for these generic producers. By 2002, heart cost $300 per patient year. By 2007, it was $87. Though much more affordable, it was still out of the reach of many. A report by Jeffrey Sachs in 2001 made the important conclusion that improved health outcomes would boost economic growth. Evidence for this proved to influence the actions of the rich, making them more apt to get involved in donation and fundraising programs for health. One of the first major campaigns for HIV/AIDS treatment, the 3x5 campaign, which aimed to have 3 million on treatment by 2005, measured their successes in the number of people treated rather than the amount of money donated. This was a key step in accountability for funding. By the year 2000, there were now new major players to be accounted for in the realm of global health financing. The Global Fund to fight AIDS, tuberculosis, and malaria was launched and gave out its first funds in 2002. As a partnership between governments, civil society, and other non-governmental organizations, the Global Fund works to collect and then provide funds for research and projects relating to AIDS, TB, and malaria. The organization does not conduct work on the ground, instead holding those they fund accountable for the wide variety of projects they undertake. They now raise and then invest nearly $4 billion per year. Started in 2000, the Bill and Melinda Gates Foundation is now the largest private funder of global health research and implementation worldwide. Working in both global health and overall development projects, their ultimate goal is to create an equitable society, especially utilizing technology to do so. Since their inception, they have now given out over $36.7 billion in funds across the 50 United States and over 100 countries. A final key player in the global AIDS response is PEPFAR, or the U.S. President's Emergency Plan for AIDS Relief. When George W. Bush was elected president, he had a reputation for coolness towards giving out foreign aid, one report even stating that Africa doesn't fit into the national strategic interests of the United States. The conservative Congress at the time backed up these statements. Over time in office, and especially with the influence of Dr. Peter Mugheni of Uganda, Bush's opinion changed, and in his 2003 State of the Union address, formally made a plea to launch PEPFAR as a $15 billion work of mercy to African AIDS relief. By May of that year, both houses of Congress had approved the initial 5-year plan. Many foreign nations then followed suit, drastically increasing their funding of international AIDS relief efforts. Global AIDS once again proved to be a political issue that could unite people across the ideological spectrum, with the AIDS lobby composed of conservative evangelical Christians, college students, gay rights activists, African Americans, and people living with AIDS. Between 2000 and 2006, the U.S. government increased funding for international AIDS prevention and treatment more than tenfold. As of 2010, they were the largest donor of public foreign aid for HIV/AIDS at $1.7 billion, followed by the United Kingdom, the Netherlands, Germany, and France. These commitments to AIDS have served as a beachhead for other global health projects, encouraging governments to think outside the box and provide new resources for funding research and development. Unfortunately, global aid has now largely flatlined, but it shouldn't be. In May 2011, an NIH study showed that antiretrovirals served more than just the purpose of treating those with HIV. They also were preventative against new infections, reducing the rate of viral transmission by 96%. This evidence means that our efforts to increase the availability of ARVs should be even greater, as they will treat those currently ill and stop the spread of the epidemic. Mezek and Prabhu propose that this could be possible if contractor overhead rates were made publicly available and then lowered, as many of PEPFAR's funds go to these costs. Ultimately, the success of HIV/AIDS programming has been due to transnational activism, innovative market coordination, new strategies for financing and procurement, and the ability to reimagine global health equity. Using a biosocial approach has been key to conducting these actions. Further, AIDS treatment can now be seen as a wedge to strengthen health systems. It can simultaneously provide the treatments it was designed to and offer primary care services. As a complex chronic condition, AIDS has already required its programs to have full-time salaried staff, modern facilities, trained community health workers, and a robust referral network. These strengths should be utilized to then build stronger health systems, training health workers further to address other diseases, conditions, and pathologies of poverty. Though there is still a great deal of work to be done to create equitable health systems and conditions, using HIV/AIDS programming as a stepping stone is a worthwhile endeavor to undertake.
The second part of our presentation is building an effective rural health delivery model in Haiti and Rwanda. Partners in Health is a global health organization that is relentlessly committed to improving the health of the poor and the marginalized. It is an institution that seeks to strengthen the health systems in the rural reaches of some of the most underserved parts of the developing world. The mission statement for Partners in Health is to provide a preferential option for the poor in healthcare. There are two main goals. One, to bring the benefits of modern medical science to those most in need of them, and two, to serve as an antidote to despair. Partner in Health's approach links delivery of high-quality care for individual patients to efforts to redress some of the structural barriers to good health, such as employment, insufficient access to food and clean water, shoddy or absent health infrastructure, high transport costs, and poor housing, to name just a few. Partners in Health began in 1987 after Paul Farmer and Ophelia Dahl helped set up a community-based health project in Cange, Haiti. Cange was a squatter settlement of displaced peasant farmers who had lost their land, their homes, and their livelihoods when the construction of a giant dam and reservoir flooded the valley. Official documents claim that those who built the dam had warned locals of the impending flood. But interviews with many of the displaced suggested that some area inhabitants were unaware of the dam's completion until water started rising, swallowing their houses and farmland. These water refugees, at least the ones in Cange, complained that most had not received any compensation from the government or the companies involved. The initial focus of Partners in Health was on treating HIV and AIDS in rural Haiti. After centuries of misrule and foreign interference, Haiti has long had some of the worst health indices in the Western Hemisphere. The prevalence of tuberculosis in Haiti is estimated to be the highest in the hemisphere. In 1941, one scholar wrote that in a series of 700 autopsies performed in the Port-au-Prince General Hospital, 26% of the deaths were deemed due to tuberculosis. The United Nations reported that in 1944, tuberculosis was the most important cause of death among hospitalized patients in Haiti, linking the high incidence of the disorder to poor sanitation and poverty. The UN predicted that for many years to come, tuberculosis will continue to make a heavy toll of human lives in Haiti. This prediction came true. The Pan American Health Organization estimated the prevalence of tuberculosis in 1965 at 3,862 cases per 100,000 inhabitants. Available data indicates that tuberculosis remained the leading cause of death among individuals between the ages of 15 and 49 until the turn of the millennium. Studies in the 1980s suggested that in this age group, tuberculosis caused 2 to 3 times as many deaths as the next most common diagnosis. By the 1990s, the situation had worsened. The high prevalence of tuberculosis was complicated by the advent of HIV. In sanatoriums in urban Haiti, some 45% of all tuberculosis patients reportedly were co-infected with HIV. The Partners in Health healthcare delivery model has 8 main purposes. Number 1 is strengthening access to primary health care. A strong foundation of primary care enables treatment of specific diseases, including complications of childbirth and also chronic diseases from AIDS to diabetes. Number 2 is providing health care and education for the poor. User fees decrease attendance at clinics and schools, especially in settings where the burdens of poverty and disease are greater. Partners in Health works to ensure that cost does not prevent access to primary health care and education for the poor. Number 3 is relying on community partnerships. Partner in Health's programs involve community members at all levels of assessment, design, implementation, and evaluation. Community health workers may be family members, friends, or even patients who provide health education, refer people who are ill to a clinic, deliver medicines, and offer social support to patients in their homes. Number 4, addressing basic social and economic needs. Partners in Health feels that achieving good health outcomes requires attending to people's social and economic needs and overcoming structural barriers to care. Through community partners, Partners in Health works to improve access to food, shelter, clean water, sanitation, education, and economic opportunities. Number 5 is working in the public sector. A vital public sector is often the best way to bring health care to the poor. Number 6 is focusing on women and children. The health of women and the health of future generations are intertwined. Women and children are sometimes less likely than men to receive household resources for adequate nutrition and health, and thus we must pay particular attention to their needs, from the design of health infrastructure to social support programs to ensure equitable access to care. Number 7, harnessing technology and communications. New innovations in medical informatics can improve healthcare delivery systems in rich and poor settings. Partners in Health has implemented electronic medical records which assist in data collection and patient monitoring, and other technologies, including communications technologies, to rationalize supply chain management, laboratory informatics, and patient transfers. And lastly, number 8, disseminating lessons learned. The science of global health delivery is nascent but growing. Information dissemination allows health providers to learn from the successes and failures of colleagues around the globe. Although Rwanda and Haiti are separated by geography, history, culture, and political economy, they have sufficient similarities to warrant comparison. Both are mountainous countries of approximately 10 million people living in an area roughly equal in size to the state of Maryland. Both are predominantly rural and agrarian. Both have been exporters of tropical produce such as coffee. Both struggle with ecological degradation, although deforestation is far more widespread in Haiti. They also share a history of structural violence, poverty, unemployment, foreign meddling, post-colonial instability and violence, and a significant burden of disease. At the invitation of the Rwandan government, Partners in Health began working in the eastern province of Rwanda in 2005. Partners in Health would work closely with the public sector. Partners in Health supported facilities would be staffed by clinicians and managers from Boston, Haiti, and elsewhere, but also by the Ministry of Health employees. New and renovated hospitals and clinics would also belong to the ministry. The head of the National AIDS Control Commission at the time pointed out that with more than 150 AIDS-related non-governmental organizations in Rwanda, fewer than 150 people were on AIDS therapy outside the capital city. An estimated 100,000 Rwandans needed such care. Along with the Ministry of Health and other partners, including UNICEF and the Global Fund to Fight AIDS, tuberculosis, and malaria, PIH planned to scale up AIDS treatment and testing while also helping the Ministry of Health build a comprehensive public sector health system in the region. In 2007, the Rwandan Ministry of Health asked IMB, the sister company to PIH, to expand to Barera, a district in the north of Rwanda slightly less poor than the districts in which PIH already worked. In 2008, PIH began supporting 15 health centers throughout the district and broke ground on a new district hospital. Built by local workers, the hospital was designed to minimize airborne infection and optimize patient flow between wards. Bataro Hospital was officially opened in January 2011, and it serves as a model for other districts. On January 12, 2010, a magnitude 7.0 earthquake devastated Haiti, particularly the capital, Port-au-Prince. Estimates of the death toll ranged from 220,000 to 316,000, and more than 300,000 were injured. Some believe that 60% of all federal, administrative, and economic infrastructure was destroyed. An estimated 2.3 million people, including 302,000 children, were displaced from their homes. The destruction in Haiti, in terms of both loss of life and economic loss, surpassed that of any other natural disaster in recent decades. One of the largest humanitarian relief efforts in history was registered in Haiti after the earthquake. Bilateral, and multilateral donors pledged $5.4 billion, and more than half of U.S. households contributed to the humanitarian response. Partners and health staff responded within hours, helping to keep the General Hospital up and running, launching clinics in 4 of Port-au-Prince's internally displaced persons camps, and providing care for thousands of victims who made it out of the city to the Central Plateau. Though Partners in Health is not a relief organization, its Haitian staff and decades of experience providing health care in Haiti put the organization in a good position to help. Thousands of other medical, surgical, and public health professionals traveled to Haiti to join the humanitarian effort.
This next series of slides is from The Virtuous Spiral by Alan Fowler. Part 3, Institutional Stability, Regeneration, and the Viable Organization. The concept applied to organizational sustainability is labeled regeneration. What keeps a development organization viable and sustained in a changing context? Reputation. The organization's collective character must stay allied to the public trust. Relevance and quality. Learning. We have to remember to link necessary change in organizational behavior. This leads us to insightful agility. So if the institution encounters problems for the second time, they have a built-in efficiency for problem solving. And human relations and working in teams. Are organizational members, are they willing to embrace their failures? And working in teams speaks to decentralized leadership. Organizational learning requires knowledge that gets translated to change. So now we're going to look at 5 key areas. First is the power distribution, and this goal is to increase the scope of authority downwards and outwards so that most operational decisions need to be approved only at the next higher level of authority. This becomes less hierarchical, or in leadership, maybe you studied lattice organization where it's flatter. It's sometimes called a flat organizational structure where you have a decentralization. For resource profile, this pertains to the protection of the core functions through self-generation of income and to spread the risk. An example of this might be to make something a budget line item. That would assure that it would be funded down the road. The culture, this speaks to increasing the trust and the ability to communicate, and you want to inoculate a sense that the organization is a living community with space for curiosity and inquiry. The learning process, we need to come up with better proxy indicators, and people need to think, people in the organization need to understand that learning is part of their job description. The relational web pertains to the dependency on a community or local government. This footprint needs to be lightened. So now we're going to look at the obstacles for non-governmental developmental organizations as learning organizations. What are their obstacles? And Fowler likes to make the point that NGOs express a lot of dissatisfaction with their own ability to learn. So I think the biggest obstacle that he really stresses is that these organizations are built on activism and they're belief driven. Now, I like to think about this. It's helpful for me to think of this as the organization's own confirmation bias. So they're going to naturally seek out information that confirms their own beliefs, which in this case might be their mission. So there's less value on reflection. There's a tendency to overpromise simple solutions to very complex problems. There's a fear of media exposure. Error and failure are often not embraced. And you'll hear Laurie Garrett sometimes refer to this as the inertia and malaise of an organization. There's also a very loose coupling between performance of aid and the amount of money allocated. And then there's a discussion about the vertical barriers between disciplines and departments. And then there's horizontal barriers between management and staff, resource insecurity, and political alignments. You'll hear the same argument a lot when they talk about the post 9/11 commission, about how the different agencies did not speak to each other, didn't communicate, and that was because of vertical barriers between disciplines and departments, and then horizontal barriers even between agencies, that sort of thing. Okay, now the next slide is going to be Alan Fowler interview at a training conference for NGOs held in the UK, and he's going to address what civil society comprises of, and even more importantly, he's going to talk about the new challenges over the next 3 to 5 years for NGOs and civil society in general. The point that he makes is that the old rules no longer apply as much because democracy and capitalization working together is being challenged globally via globalization. We have a lot of technocratic governments now where the old countries that were responsible for facilitating the transfer of money from the wealthier countries to the poorer countries, they're no longer as needed with all the new technology where people are speaking directly to each other. And thirdly, the quality of money is affected because While there might be funding for contracts, this money is available, but if you want funding to promote human rights, this is far more scarce. Okay, before you roll your eyes too much about this crazy diagram of the sandwich strategy, let me explain why I've included it. I was struggling a little bit with the complexity of Alan Fowler's discussion of the international development sustainability, particularly in our last section about regeneration through leadership. And so I took a look at some of his sources and found this 2015 meta-analysis, Social Accountability, What Does the Evidence Really Say? By Jonathan Fox over at American University. I really like this depiction of the process because it gives you a clear idea of some key entry points if you are working with an NGO, and it also speaks to Fowler's urging that we get more involved as facilitators of the process as opposed to just focusing on the actors. So I would like for you to note that the public interest advocacy and collection action is rising up from the bottom to meet the reformists who are the people with the political power to implement policy at the top. You'll notice that facilitators are called interlocutors, which is sort of a new term that you'll see a lot in some of the newer literature. And these are the people who bolster the voice by facilitating direct negotiations of expected actions with the service providers. And to summarize the last section about regeneration through leadership in Fowler, he emphasizes that most of the leadership literature base is about business for-profit leadership, and so he tells us to take care before applying to other types of organizational leaders which have unique differences. Some examples would be denial or neglect of non-economic values and norms of civil society and culture. And also, Fowler says that interventions to develop leadership in NGOs must be accelerated and more broadly framed. To democratize organizational leadership is to promote second-generation leaders because there would be a decentralization of leadership and it would make the system more robust. Also, a better balance of leadership and management skills. If you have your hand in another man's pocket, you must move when he moves. I'll close with this African proverb because I think it's a good reminder that developmental organizations need to consider the host community's autonomy when setting the development agenda.